be able to join us soon enough. Dr. Kasim, if you can hear me, you can say hello before we go into the presentation. Yes, session about the sound from this end. Thank you very much. You're welcome. Again, you can type in your questions at the Q&A and interact as much as possible. Welcome.
Good afternoon, everybody, and welcome to today's webinar. Allow me to share my screen. Good afternoon. Okay, sorry for that microphone hiccup. So today we're going to have a session on strengthening microbiology lab clinical interface through mentorship. And really the motivation for this presentation is that during the antibiotic awareness week, there was a presentation that was made by the KNH antimicrobial stewardship team highlighting the importance of awareness on antimicrobial resistance and the stewardship initiatives within the hospital. And additionally, we've actually had a renovation of the microbiology lab within the hospital. So even as I speak, I'm not a microbiologist, but I'm speaking as a clinician who uses the lab, and I'm also speaking as an infectious disease specialist who we run the infectious disease consult service within the hospital. So really, that's where the motivation for this talk, to see how as lab users we can strengthen and support the use of the lab by what we need to do before the samples reach the lab session. So that will really be the focus. And we hope that this will be one of several series of lectures that we can have to really strengthen the use of microbiology, because we know that microbiology has lagged behind, and a lot of us who use the lab, with time we actually sort of lost faith in the lab, and many people maybe logging in from other county facilities where microbiology services may not be available. Again, focus mainly on treating patients through empirical treatment. And that's a practice we want to abandon and embrace the lab, because we know that there are so many initiatives that have focused on the lab and really emphasize about quality within the lab. So I'm not speaking as a lab person, I'm speaking as a clinical person. And on the panel today, we have Dr. Ali Kasim, again, a clinical pathologist from our KNH lab, and he'll be here to support and really take additional questions that may arise regarding the lab. So briefly about the outline of my presentation, we'll look briefly at an introduction, look at the diagnostic pathway and the clinical reasoning behind this diagnostic pathway. And this diagnostic pathway will not exhaustively be covered today, but we will have subsequent lecture series to focus on this, about how do we make a microbiological diagnosis and how do we use the results that come from the lab. We'll also look at how do we optimize the use of the lab as clinical teams, and how do we optimize lab results from the lab to make optimal care for the patients that we are looking after. It's a fairly short lecture, and I just wanted to put some pictures to highlight our new revamped microbiology lab. And currently our lab has state-of-the-art equipment, including the Molditor that is shown on the picture to my right. This is a very advanced machine, and not many facilities currently have it, and it can give results within a fairly short time. So we will, maybe Dr. Kasim can tell us maybe a few things about it as we come towards the end of the lecture later on. This is the corridor. I didn't put the before pictures, I just focused on the after pictures, and you can see the beautiful colors of the lab. This is the corridor of the lab with very good lighting and the sinks. And really, the lab improvements are significant, not only in the physical infrastructure, but there's a lot of training that's also going on, and a lot of quality initiatives. And really, as the lab people have gone out of their way, we need to support them by sending appropriate samples to use the lab. So in this slide, we have three aspects that really are interlinked together in the microbiology setting or the infectious disease setting. So the ASP stands for Antimicrobial Stewardship Program. And in the hospital, we have a very robust antimicrobial stewardship program. ISP stands for Infection Prevention Stewardship Program. Again, I think this could not have been timely, because we know COVID-19 has really demonstrated the role of the infection prevention team in terms of setting procedures and developing SOPs and guiding a lot of infection prevention policies and practices within the hospital. And as microbiology or infectious disease team, we have benefited from that, because some of the interventions that are targeted against COVID have benefited even organisms like the multi-drug resistant organisms within the hospital. One of the key contributors to spread of multi-resistant drug multi-drug resistant organisms is actually poor hand hygiene among the healthcare workers. And we know with COVID-19, hand hygiene has really been one of the practices that has been embraced by all of us. So again, that contributing. So we can say we've benefited from the collateral effects of COVID-19 infection prevention practices. And then on this other aspect is DSP, which stands for Diagnostic Stewardship Program. And in Diagnostic Stewardship, really, this is where the lab team provides guidance and is really at the center of guiding microbiological diagnosis through working closely with clinicians to develop capacity and really mentor clinicians in terms of some of the pre-analytical steps that are required to be able to get the right samples into the lab. So these three programs, we currently have very strong capacity within the hospital, and the talk today has an overlap between the diagnostic, is largely related to the diagnostic stewardship aspects. And when we talk about the microbiology lab clinical interface, we are really looking at communication strategies between the clinical teams that utilize the lab and the microbiology lab team members. So we want to encourage a lot of communication between us as clinicians who use the lab and the laboratory teams that work on the samples. And most of this communication is largely through the things that we do as we send samples to the lab. So this includes how we complete the lab request forms, how we collect the samples that go into the lab, and even how the results that come from the lab are dispatched to us and how we utilize those results to help in patient management. So this is really integral. And in settings where you have a very strong communication between the lab teams and the clinical teams, then you're able to optimally use the lab fairly well. And this communication really involves having a close relationship where even we can call the lab, you can visit the lab. If you have investigations that you do not understand the results, you can take an extension, a phone at the extension of your ward and call the lab and get additional answers from the lab team. So it's really an open door communication between us as clinical teams and the teams that are within the labs. For many of us who run the infectious disease consult surveys, we find ourselves even visiting the lab to follow up on of some of the results, because sometimes even we may not have all the capacity, but the lab teams are able to explain to us some of the results from the lab. So when you're looking at the diagnostic pathway, and why I'm emphasizing this, it looks very basic. It's really because as we had during the antibiotic awareness week, a lot of the patients who come to our wards receive antibiotics for no good reason. It's like being admitted to the wards is one of the requirements, like just when you're fixing the IV line, you also have to prescribe antibiotic, and that is a practice we would like to discourage going forth. So when you're following your diagnostic pathway, for your patient to qualify for an antibiotic, you really have to be convinced that there is a focus of infection, and therefore you're giving that antibiotic as maybe empirical treatment when you've already suspected the infection, or definitive treatment when you know what infection you're dealing with. So in your patient history, some of the things that will highlight to you that a patient may be having an infection is when they have fever, and you can identify a potential site of infection. But in addition, you have to take a very detailed history to find out what could be the infection, and even to think of what organism could be causing that infection. So if a patient has features of pneumonia or lower respiratory tract infection, there are certain clinical signs that you would look out for in addition to the history that you have already obtained from the patient. So it's not just that any patient who comes to the ward, be they diabetic, be they hypertensive, then must receive an antibiotic in addition to the antihypertensive treatment or their anti-diabetic medication. You really need to justify, and even the thought process when you're thinking about the potential site of infection, you have to call it by a name. So you have to say, I think my patient has a urinary tract infection because of these 3 reasons. I think my patient has an intra-abdominal infection because of these 5 reasons. I think my patient has meningitis because of these 5 reasons. So you really have to think about where the infection is, what could be causing the infection, because those are important even when you're choosing your empirical treatment. Your treatment has to be targeted and has to be able to cross and reach that area where you think the infection could be coming from. So you've done your history, you've performed your physical exam, and you've picked some clues. The next level is really your laboratory evaluation to confirm or rule out the infection. And that's where your microbiology lab comes into play. But in addition, you'll need other supportive labs, including other biomarkers that may actually tell you that your patient has an infection, particularly if it's a patient who's coming from the community, where you're thinking that it could be a community-acquired infection. So again, you can be able to do some of the biomarkers to be able to tell you. But in addition, of course, other basic tests like a full blood count where you're looking at neutrophilia. In children, again, you talk about the left shift and additional things. So the diagnostic pathway before you prescribe antibiotics is not a shortcut that you'll just say this patient is going to the ward, they need ceftriaxone. No, you actually have to think actively that your patient could be having an infection. The infection is in a specific site, and you even think about what could be the organisms that are causing the infection in that patient, so that even when your microbiology lab results come, then you're already anticipating that particular infection. So looking at the diagnostic stewardship steps, it's a composite of several things that are illustrated there. And the first aspect that you have to ask, even as you approach this, is does the patient need a diagnostic specimen for microbiological analysis? And we, from the previous slide, we already went through what would be the things that guide you to say your patient probably has an infection. And again, another thing we have to remember, the talk today is focusing more on the microbiology lab, so emphasizing more of bacterial diagnosis, but we know, again, you can have other infections like parasitic infections like malaria or other viral infections like COVID-19 or SARS-CoV-2. So if your patient needs a diagnostic specimen, then you have to think about what specimen you'll send, and your specimen will be related to the area where you think the infection is. So that if your patient you suspect has meningitis, you have to send a CSF. You will also need to send a blood culture in addition to that. So again, a very detailed physical exam to support your history then guides you as to what specimens you need to send. So this takes us to which specimen and test to send. And we have developed what is called the Clinician's Handbook, and I'll talk about it shortly, which sort of helps you to even decide how to collect the specimen or guides you on how to collect the specimen. So appropriate guidelines and policies related to that. So how to collect the specimen and submit to the lab. Again, we have the Clinician's Handbook that I've talked about. That really is a detailed handbook about even the amount of specimen to send, the kind of bottle to send it in, the time to send it, like the interval time to send to the lab. So again, very detailed, and this is available. The Clinician's Handbook is developed largely by the lab team together with the clinical team. And it's sort of like, it's a way to sensitize the rest of the hospital lab users on what the lab can be able to do, and even the turnaround time for different specimens that reach the lab. So it's a very important tool for improving the microbiology lab clinical interface. And we'll be talking about this handbook in subsequent webinars on this forum. How to collect the specimen and submit to the lab. Again, this is very, very important. And when we communicate with the lab, we fill the lab request form. And it's in my next slide about what is the minimum threshold that we'll be using or will be required in that form. So I'll talk about it subsequently. So when you ask yourself, does the patient need a specimen for microbiological analysis? And most often, if your patient has the clues that we talked about earlier, then the answer would be yes. So specimens for diagnostic purposes are usually submitted to help identify the causative organisms. And they are not really done to confirm a clinical diagnosis. You must already have taken the history and the physical exam and already have a tentative clinical diagnosis, so that when you're sending the sample to the lab, you want to identify the causative organism so that you can target your treatment to the specific organism. And a good example is given here. So when your patient presents with symptoms of lower respiratory tract infection, your sputum and blood culture may help identify which organism is responsible. However, the caveat is the presence of the organism does not confirm a diagnosis of lower respiratory tract infection. The absence of an organism, again, does not exclude the diagnosis of lower respiratory. So you must always start with a clinical diagnosis. You must have a clinical suspicion in your patient. And this will be related to fever and other features of inflammation that the patient would have to support first a clinical diagnosis, and then the test that you do helps you to identify what could be causing that infection. So I've put here the lab request form. Sorry, it's very faint, but many of us who work in KNH are very familiar with this form. So this form is one of the early ways in which, as clinicians, we communicate with the lab. So we need to support the clinical team by making sure that this form is filled to the detail that is required. And the form, many of us, I don't know, maybe when we were much younger, we complete the form in more detail, but as we grow older in the profession, we become less and less detailed. So every detail in this form is important, especially in the microbiology lab, because these are important things that even help the lab to focus and narrow. And if they are, for example, if they are isolating an organism that is unusual, then they can say, with this clinical history, this organism doesn't really affect this area and therefore maybe may not be significant. So as a minimum, we need to put the patient's name, the patient's age, and particularly for patients who samples that come from the adult ward. If you put A as the age, where A represents the adult, that is not good enough, because we want to know that this is an 80-year-old person instead of a 21-year-old. So the age, the exact age of the patient is very, very important. The specimen type, again, is very, very important. And there's a space that is written for the specimen type. And I know in the checklist, there's a place where you also tick. So it's not good enough just to tick that you want the urine microscopy, culture, and sensitivity. In the specimen type space there, you have to put urine as a sample. So you have to indicate the specimen type. With regard to the clinical history, there's a part in the form that is indicated clinical information and provisional diagnosis. So I've put here relevant clinical history. And the importance of this is that, remember, you've gone through a clinical diagnostic pathway where you're thinking that my patient has a lower respiratory tract infection. So you have to put that, the site where you suspect the infection could be happening. And why we are putting relevant clinical history is that if your patient has other comorbidities like hypertension, diabetes, a lot of the forms that reach the lab may have that as the clinical information. But for the lab team, that may not be so relevant, because why were you sending a sample of, for example, a blood culture in a patient with hypertension? So you have to put additional history to say that patient with hypertension presented with a 2-day history of fever, no localization, like you cannot identify maybe a specific focus of the infection and you're suspecting maybe a bacteremia or septicemia. So that relevant clinical history is able to guide the team to be able to look at the likely organisms that may cause bacteremias or infections. So relevant clinical history, what basically it means is when you localize the infection, for example, you suspect it's meningitis or pneumonia or an intra-abdominal abscess, that's the kind of relevant clinical history that would be useful in the microbiology setting. And this will be something that we cover in subsequent webinars to look at it in terms of what organisms are likely to cause infections in different parts of the body because of either their normal flora and they're in close proximity in that area, and therefore they can revert to virulence and be able to cause invasive disease in certain groups of patients. So this will be covered in our future webinar. And then at a minimum, we need to know the name of the requesting clinician and the contact detail. And this is important because, for example, the lab may notice something with the specimen that is growing and may need to communicate urgently with the ward. And therefore, when they call the ward, then they need to know even the name of the person for whom the message needs to be relayed. And many people just scribble a signature, but it's important to put confidently our names when we request for specific specimens. And this is important, especially when information, we need to relay feedback from the lab. So again, we need to have the requesting clinician's name and contact. And then on the drop-down list somewhere here, then you'd have the tests that you're requesting for. And there's a long list of tests that are available, from blood culture, CSF cell count, urine culture, urine microscopy and sensitivity and things like that. So that even for, I wanted to mention at that point, at the point when I was talking about the relevant clinical history, in your patient where you're suspecting a urinary tract infection, it's really important to say that this patient has features of urinary tract infection, or features of cystitis, or features of pyelonephritis, because we know that the urinary tract is a fairly long part, and we want to know which part is likely to be involved. Is it the bladder? Is it the kidney where you have pyelonephritis? So again, the relevant clinical history. And again, this will be important based again on the samples that have been submitted to the lab. So we cannot overemphasize the importance of the lab request form. So together with the lab request form, this goes hand in hand with labeling the specimen bottles, because your lab request form will be accompanied by the specimen in a specific bottle or a carrier that will carry the specimen to the lab. So the details that you put on the form, you have to put the same, more or less the same details that you put on the form. And on the form, I think on the bottle, you have to put the patient's name, the ward location, the inpatient number, so that this can be used to identify and track the form for the patient. So if you send a completed form and a bottle that is not labeled, then your sample will not be accepted in the lab, because they cannot really identify, the specimen will not be identifiable and matched to the form. So which specimen and test to take to the lab? And really, this is guided by local guidelines, as well as the likely site of infection that you suspect following your clinical history and the physical exam. And in the hospital, we have our empirical guideline booklet that actually even gives some guidance in terms of what samples to send to the lab. But in addition, we've developed the Clinician's Handbook that will be disseminating through this forum, and it really guides on which specimen for which kinds of patients, so that your patients who have pneumonia and meningitis, they'd require blood cultures, both of them. And then in meningitis, in addition to that, you'll also need to do a lumbar puncture. When you're collecting your samples, the sterile site samples are preferred. And this is important because if you find an organism in a sterile site, then likely that that organism is going to be significant and can be the one that is causing the infection in that site in a patient who presents with compatible symptoms. Specimens should be submitted prior to antimicrobial administration, and if this is possible, and this is really a very difficult challenge we face in the hospital, because most of our patients who get admitted, even when they're not very sick, receive antibiotics, and like all patients get universal antibiotic administration. So for patients who are fairly stable, it would be good to actually collect the samples first and initiate the antibiotic after the samples have been collected. And this would really go a long way in helping to identify the causative organisms for the infections if we take the appropriate samples. A specimen has been collected must be documented in the patient's notes. So for all of us who are listening, when you obtain a specimen, please make a note in the file as part of the continuation notes, not only on the charge sheet, because I know many of us just want to document on the charge sheet, but it's important to document in the notes, and this is really one of the best practices. So how to collect the specimen and submit to the lab. So we know we have the local guidelines, and we've talked about the clinician's handbook that will specify how different specimens should be collected. And basically, the appropriate material has to be used to collect the sample. And we had in the past a shortage of blood culture bottles, but that problem now has been surmounted, and we have adequate blood culture bottles. We also have the urine containers as well as the swabs. For the specimens, you have to put in the required amount of specimen. And I know when you're getting the blood cultures, if you go to the lab, they'll show you how to fill the bottle adequately with the right amount of specimen, so that you don't have too much media that's diluting the specimen in case you put a small amount of specimen. In terms of collection, your technique, you have to have a technique for clean and safe handling. So you have to ensure a sterile procedure as you handle the patient. And then the appropriate precautions, including use of PPE such as gloves, you have to adhere to that so that you're not putting yourself at risk of additional risk of infection. So what's the importance of a good specimen collection? And this is really for us as clinicians who are using the lab. So if we have a good quality, if we expect a good quality of result, then we have to submit a good quality of specimen, because you don't want to send a sample to the lab and then they grow something and then they write in the report that this is most likely a contaminant. Because if it's a contaminant, you're not going to treat the patient of the contaminant. The contaminant means it's on the skin and you will not be able to treat the patient. So it means you'll have missed the opportunity to identify what is actually causing the infection in the patient. So a good quality specimen is key to accurate lab diagnosis and confirmation. It also directly affects patient care and patient's outcomes. It influences therapeutic decisions, because if the specimen gives you an organism that is not really required to be treated and your patient is still very sick, then it means your patient will continue being sick because you cannot start empiric treatment for something that you have not totally isolated what could be explaining the sickness in the patient. In addition, a good quality specimen impacts hospital infection control, because it's going to give you accurate information and that is useful for surveillance. It impacts patients' length of stay, hospital costs, and laboratory costs, and influences lab efficiency. So what this means basically, if you're always sending poor quality specimens to the lab and isolating contaminants, it means your patient will stay longer in the hospital, incur additional costs. And for any specimen that you send to the lab, it's already charged on the patient. So it means the more samples you're going to send, the bill for the patient will be going up because you're not following due procedure. So we need to be careful about the quality of the specimens that we are sending to the lab, so that we are not only getting contaminants being isolated. So as a general guideline on specimen collection, these are just general standard requirements that you follow standard precaution guidelines, and you treat all specimens as potential biohazard. So you have to be careful and take enough precautions, standard precautions, including minimum wearing your gloves as personal protective equipment. Collect the specimen before administering antimicrobial agents when this is possible. There are certain situations when you have to give the antibiotic because your patient is likely to have a poor outcome. This includes when you're suspecting meningococcal meningitis, for example, or if your patient already has sepsis. So in this case, time is of essence, and you will need to start your antimicrobial agents fairly early. But in most other settings, you really need to be able to take the history, collect your samples, even if it means at the A&E, and then now start or prescribe your empiric antibiotic. And remember to modify your antibiotic once you already get the results from the lab. Collect the specimen with as little contamination from indigenous flora. And I think of notorious for this is actually the urine samples that are submitted to the lab, because urine is very, very tricky. You have to collect a midstream catch of urine. And many people, even as healthcare workers, explaining this to our patients sometimes can be difficult. And then even for patients like who are female, it's technically sometimes very difficult to get a clean catch of that urine. So we really just need to find ways to minimize the risk of contamination. On the webinar on 23rd of November, Dr. Kasim put it very, very clearly that really if you send urine that you've collected from the urine bag that has stayed for more than 6 hours, then you're wasting the bottle, you're wasting the lab time. Basically, you're wasting a lot of resources because that sample will not be useful. In addition, you need to clearly label the specimen container with the patient's name, date, time of collection, and even the ward and the patient's number, so that this can be matched with the form, just to emphasize that. You need to collect an adequate amount of specimen, because inadequate amounts may yield false negative results and may be rejected by the lab. But the lab tells me that the rejection rate based on adequacy of sample is very, very low. So this, we need to keep it up and continue submitting adequate samples. Identify the specimen source and or specific site correctly so that the proper culture media will be selected during processing in the lab. So this is really, really important, and I cannot overemphasize. You have to say the source of the specimen, and whatever you write has to be concordant, because sometimes you can put a specimen type there up on the form where you put like it's CSF. And then when you come down to the checklist box, you put its urine. So sometimes the lab is so confused. Is this a urine sample? Is this a CSF sample? And when there is discordance, they're likely to reject your specimen. So you really have to indicate the correct source of the specimen and the site. And then timely transportation of all specimens to the lab to ensure survival and isolation of some organisms that are difficult to isolate. And also timeliness prevents overgrowth of more bacteria that are likely to thrive. So it can overgrow and kill the bacteria that's actually causing the specific disease. And then microbiology should be informed in advance if there are any special requests that may require special handling. So again, they're just a phone call away, and they can even provide guidance in terms of what bottle to put it in and how to send the specimen to the lab. So again, microbiology team are just a phone call away. Clinicians should consult the lab to ensure selection, collection, transportation, and storage of patient samples are performed properly. So sometimes, especially the surgical specimens, may be very precious because the patient has gone to theater, an infection is suspected, the sample is collected. So you may need to consult the lab for additional things and really to keep those patient samples preciously, because when a patient goes to theater, it's unlikely that they'll go to theater twice to obtain another specimen. So we consider those as precious samples and they need to be handled carefully. Another thing, and this is from the lab team, is that sometimes samples are sent directly from theater for patients, and the form may not indicate the ward where the patient is going to. So that is an omission, and it needs to be clearly indicated that although it's coming to theater, this is a patient who's coming from maybe 5B or 6D. So that has to be clearly indicated, because remember, theater is not where patients stay overnight or for several days. So when the result has to be relayed, it will not be relayed to theater, but it will need to reconcile with the patient specimen, with the patient file wherever the patient is residing. So we need to indicate the ward where the results will be sent to. And the form actually mandates, it says to be sent to, then you indicate the ward where the patient comes from. So in terms of accessing and interpreting the results, so remember my talk is not focusing so much on what the lab will do with your test, but it's looking at how do we as clinicians send things to the lab, and when results come from the lab, how do you use those results? So an effective two-way communication system between the microbiology lab and the clinical service is required. And I think in KNH, we've already made a lot of inroads in terms of strengthening that But in other facilities where some of you may be logging in from, this is one way in which you need to cultivate that communication, so that as the microbiology lab and the clinical team, we have to work as one, so that in the end, our patients benefit from this communication. Results must be documented in the patient's file. Just like we said, specimens that have been sent to the lab have to be documented. Even results have to be documented in the patient's file, and results should be appropriately interpreted. And what does this really mean? There are several key points that are related to interpreting microbiology results. And this I really want to emphasize, because when we go on our consult surveys, we are consulted because an organism has been isolated. So we are being consulted in the tail end of the whole process. And that's why I really wanted to make this presentation today, so that as ID team, we want to be involved from the beginning. When you are suspecting an infection, if you need additional help from us, involve us from the beginning. But a lot of the times we are called because an isolate that has never been seen before has been reported by the lab. And now the ID team has to come and review the patient and make a judgment based on that. So when you get your results from the lab, you need to ask yourself, is the specimen appropriate for the suspected infection? And a number of times we are called because a urine sample yielded some very resistant organism. And when you go on the bedside, you even find that the sample maybe was collected from the urine bag. The patient is catheterized, and you're told that you might find the doctor who actually collected, and they tell you they collected the sample from the bag and all that. So that means even to start off with, the specimen was not appropriate for the suspected infection. And remember, we talked about that you have to have the clinical diagnosis first. You have to have asked for features of infection in your patient. And we know for a patient who has a urinary tract infection, how they present with, be it a lower urinary tract or an upper urinary tract. So not all isolates from the lab will have to be treated. And a number of times we come, we review your patient, and then we tell you remove the catheter or change the catheter, send another sample, no treatment. And I know many of you get upset when we give such a recommendation, but this is because a lot of the times in your patients who have catheters, some infection can ascend to the bladder and they colonize the bladder without necessarily causing infection. So your patient may not be having features of infection, but what you've isolated is actually a colonizer because of the presence of the catheter. So a lot of times we may not come and prescribe the antibiotic you are hoping, or the magical treatment that you're hoping we'll prescribe, but we'll require you to do additional things and send the right samples to the lab. But I'm hoping from this presentation, we'll be doing the right thing and sending the appropriate samples to the lab. The other question you want to ask is, how was the specimen collected? And is it sterile or non-sterile specimen, and have been labeled that? And then are the organisms isolated likely to be pathogenic, or could it be a contaminant? So this is a very, very important question. And most often, sometimes you are called to review a patient where a blood culture result isolated coagulase negative staphylococci. So coagulase negative staphylococci are very abundant on the skin. And if you don't clean your skin well and ensure a sterile procedure, you can actually inoculate the blood culture bottle with your staphylococci, and that's what they'll grow. So we do not consider it as a cause of infection in a lot of the patients, unless there's a certain criteria that is met. So most often we'll consider that they may be contaminants. Another thing to remember, another example is that there are bacteria called Enterococci. These are gram-positive bacteria that are found within the intestines. And they also cause urinary tract infections, because most of our organisms that are in the intestines just move anatomically and are able to cause urinary tract infections. In addition, again, Enterococci can cause intra-abdominal sepsis. However, it's a very rare cause of lower respiratory tract infection. So if there's an isolate of a patient where Enterococci is isolated from the lower respiratory tract infection, it doesn't, it may not be really the organism that's explaining that infection, and most often we'd have to query. So really, when you call us as ID people, we come and look at the notes and make a lot of judgment and interrogate them after. And a number of times we may actually ask you to repeat a sample, or we may just directly call the lab and send a different sample to the lab. So not every organism that's isolated from a patient requires treatment, and there has to be additional judgment based on the results that is obtained from the lab. Also, many non-fermenting gram-negative bacilli are environmental and are uncommon pathogens. So a lot of these are found within the environment, things like Acinetobacter baumannii, Pseudomonas, and they are found everywhere. So if a patient is admitted to the ward and then you take a password from that wound and then you find they have Pseudomonas isolated or Acinetobacter, and that wound does not look like it's actively inflamed on the edges where there is no evidence of cellulitis, then if you call us, we may not even give the treatment for that patient, but we'll make a judgment and say we need to take an additional specimen by probably taking a biopsy at the edge of the wound, and so that you're sending the appropriate samples and not just isolating contaminants. So what this slide is saying is that when the results come back from the lab, in terms of making judgment whether to treat the patient or not, it needs additional interrogation of the process of which the sample was obtained, the supporting clinical history from the patient, and other additional factors that we already know whether those organisms can be pathogenic in that area or not. The caveat to that is that in addition to that, there may be host factors that make the host to be vulnerable to certain organisms, and we have to make that as a consideration, so that in certain hosts, some organisms that are really non-pathogenic can now be opportunistic because of certain forms of immunosuppression in the host. So those are additional things. So when you call us as for an ID consult, those are the additional things that we come and interrogate from the patient and even from the file, and then talking a little bit more to the lab before we can make a final judgment. Another thing in terms of interpreting the microbiology results is that results of in vitro susceptibility. Remember, the lab will do a lot of things and then it will give a report. And in that report, it will say what they have isolated and what is the sensitivity pattern of whatever they have isolated. So sometimes the in vitro susceptibility testing may reflect likely clinical response in vivo, but this again may be influenced by the site of infection, the age of the patient, or severity of illness. So when you get a report that has like so many antibiotics that are sensitive, when you're making a judgment, there's additional criteria that you use to select the most likely treatment for that patient. So we are lucky that we have the empirical guidelines, so that if you isolate an organism for which you had already started some treatment and that organism is sensitive to the treatment that you've started, you may need to continue. But beyond that, you may need additional information such as pharmacokinetic and pharmacodynamic consideration to select treatment for certain groups of patients. And when you're talking about the pharmacokinetic, this is where we are looking at how is the drug absorbed, how is the drug distributed, how is it metabolized and eliminated from the person. So these are additional details that we make consideration for in terms of choosing an appropriate antibiotic for your patient. So you want an antibiotic that will be able to reach the site of infection based on a specific kind of patient. But additional consideration is that if a patient is very sick and has renal or liver disease, and some of the antibiotics may not be suitable for that patient, then that's additional criteria that we use to make a judgment on what final treatment to give the patient. So I've come to the end of this talk, and really this talk was emphasizing the importance of what do we need to do as clinicians to improve how we use the lab. And particularly in KNH, we have a brand new lab. In addition, we also have a very good team under the guidance of clinical pathologists. So how do we as clinicians support the lab so that in the end, we can be able to get good results from the lab and be able to use the results to improve our patient management. So we need to optimize the use of the lab. And what we hope to do is really to train a lot of us on different aspects. So we'll have additional sessions where we'll focus even on antibiotics. We'll focus on lab collection of lab specimens, and really disseminating the clinician's handbook. So we will share with you a tentative calendar and work through the research office to really have a way of disseminating all the information that we know, so that together we can be able to improve the lab, and we can be able to optimize. Because when we use the lab well, then it's likely to result in shorter stay, and our patients are likely to have better outcomes. So let me stop there, and then we can open the floor for Q&A. Thank you very much.
Thank you very much, Dr. Maritim, for that wonderful and informative presentation. Indeed, we've seen a lot that needs to be done and a lot that goes on in the lab, and especially in the continuum of care. Except that most of the time as clinicians, we treat the lab as a separate, the laboratory as a separate entity, and our clinical work as a separate entity. And that shouldn't be the case. That shouldn't be the case, as we have seen. And just some additional comments on what we've learned from this presentation, so that you've seen that we come all the way, it starts all the way from us as clinicians, from the time that we take history, from the time it will guide on the kind of request that we make, the kind of sample that we request for, and how we collect the samples. And maybe just to add a little bit more on the area of errors, because this is actually what you've touched on. When we do the right thing, when we have the right history, we take the sample in the right way. Eventually, what we are avoiding is what we call the diagnostic errors that we make. Because once you have the wrong history, you have the wrong request, eventually you'll have a wrong diagnosis, and you'll end up treating the patient with the wrong medication, which leads to other adverse effects, which you've seen. It has a whole impact on the patient, including the length of the hospital stay for the patient, and even having to collect other samples, and it's touched on even the cost to the patient. So it's really important on how we do this, and we are really appreciating this conversation about how we do our laboratory work right from the beginning to the end, and how we get feedback, and how we need to follow up even from the lab on the kind of samples that we have, on the kind of results that you get. Once you get those results, are they just the pathogenic organism that you're dealing with, or it's those what we call the contaminants? Before we give that antibiotic, what are we thinking about? Do you just go ahead or do question on the process that has taken place? And even the transcribing of the results. Let me just touch a bit on that. What we call the transcribing errors that we take when we are giving that information, when you're filling in that request form. We've talked about the patient's name, the age, the clinical history. If we don't do that right, it leads to what we call the transcribing errors. We might end up even treating the wrong patient. We have most of the time as clinicians, we take the sample bottles, or even as the laboratory, when you're taking the sample, we take the sample bottles, we label them at a different location, which is separate from where we are taking even the samples. And sometimes you've had to deal with those transcribing errors, or a wrong sample being taken to the lab for the wrong patient. And this is a really important conversation if you want to give a whole patient care we want to give wholesome care to these patients. So thank you very much. We will go on to some of the questions, some of the comments that are here. Thank you for our attendees for your comments and your questions. So maybe we'll start, even as we start, we'd like to hear a word from Dr. Kasim. Even before we start on the call, from Dr. Kasim from the lab, if you can now be able to join us and just give us a comment on the presentation, even as we start. Thank you.
Hello, can you hear me?
Yes, we can.
Okay, thank you so much for inviting me to this webinar. I think we are really all excited about the kind of collaboration we are trying to create and, moving forward, as you said, create this wholesome, management of our patients. And at the end of the day, that's really our goal. Our goal is to give the best of care, to our patients. So that's why we are looking at the various areas that require input, the various gaps that exist, and how we can improve. I mean, we are the top, KNH probably is the top facility in this country and should actually be able to give the best care to the patients that visit us. So thank you so much. I'm excited to be part of the multidisciplinary teams, including the antimicrobial stewardship and all the other teams that are managing patients within the facility. Thank you.
Thank you very much, Dr. Kasim, and thank you for the work that you're doing with that. And even now that you've mentioned the antimicrobial stewardship, I think Dr. Ewak, before you go, you can give us a comment on that. You've mentioned how the laboratory and the processes can lead to diagnosis of infections and how we're giving antibiotics. Please, you can give us a comment as you also invite Rosalind Kinuthia, who will be taking us through. Oh, sorry for that. Dr. Ewak is not able to speak out loud currently, but Dr. Rosalind Kinuthia is stepping in on her behalf. Dr. Rosalind, you can give us a comment on the antimicrobial stewardship and how the laboratory plays in all this. Thank you.
Hello. Can you hear me?
Hello, Dr. We can hear you loud and clear.
Thank you. Sorry, I'm in a bit of a noisy place. So thank you, Dr. Maritim, for a very well done presentation. And my just my contribution to this is she mentioned the triad of AMS, Diagnostic Stewardship, and IPC. And these three have to work very closely together to ensure that we have antimicrobial stewardship and diagnostic stewardship and IPC to improve the patient outcomes in terms of infection. So in terms of AMS, she mentioned we have an antimicrobial stewardship committee in the hospital. I am from pharmacy, so our chair for the committee is Dr. Loisa Chieng, an ID specialist. It's a multidisciplinary committee. And apart from pharmacy being key because of the medications that are being used, lab is also very key to ensure that our antimicrobial stewardship runs well and we have proper outcomes, because we depend so much on what they grow and the susceptibility patterns. And this will also contribute to what we have in stock. So we have to work together very closely, lab and pharmacy, to ensure they are also testing for what we have in our formulary and in our stock. And then that way we are able to produce results that are usable in our setting. So from pharmacy, of course, we are committed to ensure that we stock according to our formulary all that we need for the patients in the hospital. And yeah, just to re-emphasize again, lab and pharmacy really work together to ensure that this is done. Thank you. I think I can contribute later as we move on. Thank you.
Thank you, Dr. for those comments. And now we'll have also a comment from Dr. Nyukuri, as you also tell us about something to do with the sample collections, and asking about how do we do the urine sample. And this is a tricky one because that's where we've had a majority of problems. You even mentioned it in the presentation that when you go to collect the urine from the urine bag, that maybe you can mention just a mention on the collection, as you also give us your comment, your starting comments, Dr. Nyukuri. Welcome.
Thank you so much. Thank you, Dr. Maritim, for the wonderful presentation. It is timely, and a lot of what you've said is what we encounter when you are called or when you're consulted by various departments, and it's the same questions that we do ask. And I do find most of the time, actually, we end up not prescribing antibiotics or stopping antibiotics as opposed to adding or starting a new drug. And just to touch on a few issues that have been raised, one on the issue of urine. Yes, you know, when you're interpreting, when the lab is interpreting the urine results, one of the most important things is the colony count. And you'll realize that urine is a very good culture media. And if urine stays either in the urine bag or in the collection bottle for more than 2 hours, it will, the bacteria in that, in the urine will propagate and will grow. And therefore we end up getting a false colony count. And I think it's a very common thing that we see when these samples are collected. They are, you know, put somewhere, or they're aggregated somewhere and then probably taken to the lab at the end of the ward round or at the end of sample collection, or waiting for somebody to take it to the lab. And I think this is one of the challenges we do encounter when we're interpreting the results. The colony count does not correlate with the symptomatology of the patient. And so it's important after collection to take it within 2 hours, preferably as soon as possible. Which sample needs to be collected? We said, especially in the adults, a midstream, you collect a midstream sample. I know today we had a talk in the morning, and it's in the pediatric population. It may be challenging to do that, but again, this is also where when we have all the information, including the clinical and physical signs that the patient has, it helps in interpretation. If you are unable to collect midstream urine, you can collect one from a freshly inserted catheter, not one that has stayed for, you know, a long time, and it already has a biofilm. And then I think another thing I wanted to just add on was I think sometimes the lab results do get us by surprise. That is, what has been reported is basically not either what we expected or what we are seeing the patient has. A good number of times I've been consulted on patients who clinically they are stable, or the wound in question is very clean, but this patient has grown multi-drug resistant bugs. And you're asking yourselves, should we change the treatment, or should we add, or should we, should we just, continue the course? And I think it's very important to look at the clinical history of the patient, to look at the physical examination, to look at the whole sample collection and transportation cascade as we are interpreting these results, so that we don't end up giving patients unnecessary antibiotics. And I think many times I've told the clinicians, we really don't need to do much here. This is either a colonizer or a contaminant, and let's just hold course, because indeed, if it was this drug resistant and we are not treating it, and we might find probably it's 5 days to 1 week down the line, the disease would have progressed. So things should tie up. We should not forget our medicine when you're interpreting the results. Thank you.
Thank you very much, Dr. Nyokuri, for those very important comments as we continue then to learn about how to integrate these services, how to integrate our services to our clients through the laboratory services. I'll welcome Dr. Rose Nyabanda, who is with us also to give us comments on the presentation. Even introduce herself and give us some comments on the presentation. Welcome, Dr. We are glad to have you.
Yeah, thank you very much. I would like to thank Dr. Maritin for an excellent talk, and it's very timely, as the previous speaker has just said. And it's timely in that we are having a lab upgrade, not just in microbiology, but in the other labs. We are getting new digital equipment, and we are also going to roll out LIMS, Lab Information Medical Systems. And what she has said, I would really like to emphasize about proper filling of request forms, and also the proper specimen collection, and she has done it very well. And why we are talking about filling is that in the LIMS, we're even saying that we'll not allow you to proceed if you have not filled the earlier areas, so that we can have a complete well-filled form. And she has told you the usefulness of it. Of course, we all know it. It's just that for some reasons, some people normally don't fill it. So we'd like to, this talk is very good, and we hope that we'll continue to improve on our services and our efficiency. And as we do the proper sample collections, we hope that our results will also be timely, and will be ultimately to really help our patients. So I would like to thank you very much for the talk, and we hope to continue to give more of similar so that we can improve our services. Thank you very much.
Thank you very much. As you can see, there's some innovations are coming up, and even now how we can integrate even the services with the information system, with the LIMS coming up. Thank you very much for that. We'll now go to some of the comments. Our panelists, we've seen a number of comments saying they've had a wonderful presentation and they're learning a lot from the presentation. Thank you for those comments and for joining us all the way from Kisumu and all over. We'll start now with the question about the quality assurance of the lab. Maybe Dr. Ali, you can help us with this, where you can comment about quality assurance. How do we maintain a quality assurance in the lab?
Thank you so much. So I have to say that our laboratory at KNH, the microbiology laboratory, is ISO accredited. It's already attained that standard. And of course, part of the quality management processes before you become ISO accredited include the fact that you should be engaged in what we call internal quality controls. And in microbiology, sometimes it's difficult to understand, but we are talking about use of what we call ATCC organisms. These are standard organisms that they're manufactured in the US and distributed all over the world. And we basically use those to make sure that our systems are able to reproduce. If you're talking about an ATCC for Staph aureus, it's able to reproduce that same Staph aureus, including its expected susceptibility pattern. And we use the same for other organisms as well, E. coli and Pseudomonas, to make sure that our laboratory is able to reproduce those results. Thereafter, the laboratory is also enrolled in what we call the external quality assurance programs, and these are international. Currently, we are involved in one that is from the Royal College of Australasia. Basically, we get samples and known specimens that are shipped to us, and we identify and give back results, and then they're able to basically mark us and tell us, how we've performed in this. And this we've been performing consistently well. in this. So again, we also are enrolled in external quality assurance programs with the WHO as well. So at the end of the day, we are talking about a laboratory that's able to produce reliable and accurate results when it comes to microbiology. Thank you.
Thank you for that. On to our next question. Yeah, we have some comments. I mean, it's of importance to optimize isolation from Mula coli. Indeed, we've been told that the timing of how we collect the sample from the time of even how much the sample stays in the lab. Thank you for that. Another question is on the maybe human resource in the laboratory. Is a concern by one of us, Guido, who says a lab technician is supposed to obtain throat swabs at some. So sometimes in the human resource for health, we find that we have we perform different functions that across board. So maybe just a mention on that, and we can have Nyabanda. You can tell us something on that, Mr. Nyabanda. Thank you.
Sorry, just repeat that question again.
The question is about the human resource for the lab. So there's a concern about there are some who say which procedure is for which people. I know even at some point in the clinical setting, there is the doctor taking the sample, there's a nurse taking the sample. Sometimes we have phlebotomy, sometimes we have the lab people coming themselves to take the samples, and it's difficult to draw the lines. So maybe a comment in that area.
Okay, I'm going to comment and maybe Ali can add something. First, the lab tells me that they don't have somebody called a phlebotomist. That the phlebotomist is really a laboratory technologist, and it's the technologists who withdraw samples. We also have doctors withdrawing samples and sometimes the nursing team. However, we all need to continue to be trained on this because the way you have emphasized about when it comes to urine collection, which specimen collection, the timeliness, and which bottle is for what. So we really need to be retrained on this. But ideally, the laboratory technologists know how to collect the sample. The sample goes to which bottle, what time, and something like that. So if the others are helping them in one sample or the other, then they should be trained so that they do the proper collection, so that the results, the specimens are not contaminated and things like that. Yeah, that's what I would like to say. Maybe Ali can add something.
Thank you so much. So, I mean, sometimes we get these scenarios where a patient comes to the lab with a request form that is reading HVS, high vaginal swab, sent by a doctor who's indicated some clinical information nicely saying, pus, coming from the cervix, or inflamed cervix, or, patient has vaginitis. And I mean, at the end of the day, what I'm trying to say is that if certain samples are very sensitive, if the doctor who's examining the patient has, the ability to take a specimen, say if you've done a speculum as a doctor and you get out of there and then start writing a lab request form to send a patient to the lab for an HVS, a laboratory that does not even have a side room, and probably the patient has to start explaining themselves, a speculum is not available, and so on. We have to look at everything. So I would say our doctors, of course, should be trained. If the swabs or specimen collection materials are not available, we avail them to the various clinics. If you're the doctor seeing a patient and you find an inflamed throat, you should be the first person to pick that specimen. Avoid having to send patients, from one place to the other. If we are able to, get those specimen collections in our various clinics, then we should be able to do that. Same thing, if I'm the doctor seeing, we used to do this some time back, of course, at some point we start lagging behind. You are admitting a patient at, A&E. You are the first line person to take specimens. So you take all the possible specimens, including blood cultures, and so on, and lumbar punctures, because after you leave that patient is going to be started on antibiotics. You already prescribed an antibiotic. So take that chance to have all the specimens collected and sent to the laboratory. Of course, when some of these patients come to the lab, it's a throat swab. We do not return them. We do not send them back. We will still go ahead and take the specimens. However, we have to look at really, care for our patients and make sure that we do not subject them to some unnecessary, discomfort. Thank you.
Thank you for that. That especially on the comment on not sending the patient back and forth and telling the patient things. Now, Dr. Maritim, tell us a bit more on this question: which is more sensitive for bacterial infection? Is it the CRP, the PCT, or ESR? And how high should it be for a clinician to intervene? There are two questions on those regards. When do you use the CRP, the ESR? Thank you.
So when you're using those we call them biomarkers that help you to make a decision when you have a patient who presents, for example, who presents to the hospital and they are sick and they have a fever. So between the three tests that you've mentioned, the procalcitonin is more specific for acute bacterial infections. So more sensitive, so to speak, for acute bacterial infections. CRP, on the other hand, would be increased in an inflammatory process. So remember, some inflammatory process may not necessarily be infectious. For example, if a patient has an acute exacerbation of, for example, if they have rheumatoid arthritis or systemic lupus erythematosus, those are non-infectious inflammatory conditions that would still cause an elevation in your C-reactive protein. So C-reactive protein is really not very, very specific, but it will tell you that there's inflammation that's happening somewhere in the body. ESR of the three is the least specific, is the least sensitive, because there are so many things that can elevate the ESR: infections, inflammatory conditions, other additional things, like if a patient has a low hemoglobin, the ESR, because you're looking at the rate at which your erythrocytes sediment. So in patients who have anemia, they take long to sediment, and therefore your patient can have a high ESR even in the presence of anemia. So when you're interpreting this result, you really have to keep in mind what is the history, what is the physical exam, what's your working diagnosis in terms of the patient. So they are not magical, they'll not help you much. You have to interpret them with other additional history. So that, for example, in your patient who gets admitted to the hospital who has fever, an acute fever, and you do, for example, the three of them, and your procalcitonin is very high, then you'd suspect that they have an acute bacterial infection. So you would need to do additional tests to try and find out what is this bacterial infection and where is it. So the history would have guided you in terms of, is it in the lungs, is it sepsis that's generalized everywhere in the body. So again, to arrive at this, you cannot use these markers just blindly. You have to correlate them with the clinical history. And in terms of even the cutoffs, the lab where it's being done would really interpret for you what are the different thresholds for the interpretations of these tests. So what I'm trying to say in summary is that these tests cannot be interpreted in isolation. They have to be related to other additional tests, for example, even your blood counts that you will have done for your patient, and other additional relevant clinical history. So we don't want to use them just in isolation. They will not replace other diagnostic tests, but they are used in addition.
Thank you, Dr. Maritim, for that clarification. Dr. Kasim, if you could kindly highlight on the roles of the concomitant laboratory tests in the diagnosis of infective agents. Is it the urinalysis, the CBC, and peripheral blood film, and also on the role on the role LMIS that would link the lab clinic to allow for appropriate interpretation.
Thank you so much. So definitely, I mean, for us, say in microbiology, we sometimes do not, get, say, the history of the patient and so on. But it's very vital for us to have, if it's urine culture, we cannot interpret it without having, urine dipstick results and as well microscopy results for the same. Because remember, as we said, clinical history is important. The clinical suspicion of a UTI is important, but we also have to add, presence of pyuria based on urinalysis results, and then thereafter add clinical, clinically significant uropathogens having been grown in significant counts as appropriate. So all that have to be used before even we make an interpretation of the culture results. So I really cannot overemphasize the importance of these results. However, I know that sometimes not all the results in microbiology, we may not have, the CBC, for example, with us. But hopefully, as we are saying, the LIMS, the laboratory information system, when we are able to have that running as soon as in the next few weeks or months, then we should be able to actually integrate and make more sensible, interpretation of the work that we are doing in our laboratories. So definitely the role of LIMS cannot be overemphasized as well. Yeah.
Thank you for that. Maybe Dr. Nyabanda, you can weigh in on this next question, how the labs have been able to use the structured tools to minimize pre-analytical, analytical, and post-analytical errors. Can you tell us a bit about that, and can invite even Dr. Ali to comment on the same thing? Thank you. Dr. Nyabanda, you can get it? Or Dr. Kasim, you can go ahead on how the labs have been able to use.
Okay, so I mean, I don't know whether this is a comment generally on the laboratories, but I mean, our laboratories at KNH, as soon as we have, say, the LIMS running, we are talking about being able to interface all our equipment, and the interface is actually bidirectional, so that the results that you request from your ward, we will be able to, the equipment will be able to pick up that request. And remember, the samples will already have been barcoded and so on, and the equipment, even the ordering of the equipment to do certain number of tests or certain specific tests will not be manual anymore, since the interface is going to be bidirectional, and the equipment will pick up that this barcode has this number of tests requested on it, and will be automatically able to run those tests, assay them, and then feed that information back to the laboratory information system for the clinician to get those results on the other end. So at the end of the day, a lot of those pre-analyticals in terms of transcription errors, names not being clear, identifiers missing, and so on, or transcription errors, the wrong results, being fed in for the wrong patients, all those will actually be catered for. For the analyticals, definitely the quality processes in the laboratory are in play. Most of our quality processes are in such a way that a result is not released if the quality processes for that day they're not passing, for example. So all these systems have been put in place to reduce those errors to bare minimum or eliminate them altogether. Thank you.
Thank you for that. We are now actually winding up our session for today, and we really thank you for your continued, our attendees, our participants, for your continued support and your questions and the comments you're getting. A lot of thank yous, a lot of people saying they're going to take the information back to their centers. And thank you for that. Hey, Dr. Nyukuri, if you're with us, can ask you to comment on this other question on how the role of investigating sources of fomites in septic patients without an obvious focus. How is it done? How are these samples collected? And also on the patients who collect their samples, on the approach on the patients who have collected samples, how do we ensure that the collection is done correctly? Like the ones we give the stool, we ask for stool, we ask for urine, we ask them to bring it to the lab. Is there with us, Dr. Nyukuri?
Yes, I am. Thank you for the question. I'm thinking of this patient who has maybe a fever and has maybe low blood pressure without an obvious source of infection. And now you're wondering, what is causing the patient to have this sepsis or this septic shock? Which samples can I look for? Which investigations can I do? And I think this is one of the most challenging consults we ever get because you have to look at the patient from head to toe. You have to go back to the history and see if you are missing something. Remember, common things also occur commonly. And then look at is this a medical? Is this a surgical patient? Is this patient intubated or not? Is this patient catheterized? Is this patient having central lines? Does this patient have an implant? And so on. And this information will help you decide on which samples to collect. So I'm thinking, I remember two cases that we were consulted on in the last week or so. So the first patient was a post-surgical patient. And this is probably about 13 days post-surgery, not intubated, but has been spiking fevers. And, from physical examination, there's nothing you can get. Clinical history, the only relevant thing is the surgery that was done. On examination, you look at the site of incision, it has healed. So you're starting to ask yourself, where is the source of infection? What will I treat? And in fact, the patient has been on antibiotics and is not responding to antibiotics. So this is where you need to look at, is there a hidden source or a hidden abscess? The site might be healed, but there might be an abscess hidden somewhere in the pelvic region that is causing this patient, to spike fevers, and you need to look for it. Was there something actually maybe left inside post surgery that you need to do imaging to look for it? So basically, what I'm trying to say is there's no one rule that, for all these patients, you have to do this. It's very important for you to be guided by the past history of the patient. When you get a patient who is intubated, like in the ICU, and also presenting with a similar scenario, of course, the first thing you need to look at is, are we having ventilator-associated pneumonia? And we know how pneumonia presents. There'll be a new infiltrate on chest X-ray. There'll be increased oxygen demand. Probably the supporting pressures will increase. The respiratory rate will increase. So when you put all these together, then it will help you. It will guide you in terms of identifying the source and site of infection and potential pathogens. And the good thing with doing this is you'll be able to pick the right sample. And as you're starting empiric treatment, you'll be able to start the patient on the right empiric treatment. Let's not forget also things like fungal infections, which I think quite a number of times we don't think about, especially in neutropenic patients, because they might be the source of the source of this undiagnosed infection. So again, clinical history, physical examination is very important. It's more important than any antibiotic you will throw to the patient. It's more important than any blind test you will do. Because one danger of doing a blind test is, if you get a positive test, are you sure that this is the cause of infection? Or you may end up treating actually a colonizer or a contaminant. And then you find out that the patient is not responding. The second question, kindly repeat the second question to me.
The second question was on the samples that the patients themselves collect, on how are we able to maybe enable to make the right diagnosis and ensure that they are collecting the right samples. For example, we give them the bottles for urine, for stool, and they might use the wrong procedure, the wrong approach.
Again, thank you for that. I can only think of 2 samples where the patient can collect probably unsupervised, and this is stool and even a sputum sample. Probably you'd really need to explain to the patient that this is what we need. We need you to produce a lower respiratory tract sample. You need to take a deep cough so that you get sputum and not saliva. The other samples, especially the ones from sterile sites, urine is supposed to be sterile. I think the patient must be supervised so that you get the right sample. Giving the patient a bottle and telling the patient to go to the toilet to pee and bring back the sample, you are not sure what the patient has brought. Because again, even when you say midstream urine, you need to clean the urethral opening before you collect the sample. So just if the patient is not supervised and given the correct instructions, definitely you are going to get the wrong samples.
Thank you for those comments. We are now winding up. We'll do our last round, as even Dr. Kasim adds onto those last comments. Dr. Ali Kasim, you can go ahead as you also give us your final comments for this session.
Okay, thank you so much. So I think a lot has been said, especially about specimen collection. That probably for me was or should be the take home for most of us from this meeting. And I want to add that there are certain, as we're saying, sterile, sites, urine, CSF, and so on. Occasionally, you get these catheters or devices that are in situ, in the bladder or in CSF spaces and so on. It is very important to mention that in the history or capture it in the request forms, yeah? Because at the end of the day, you can sometimes grow, even say from a CSF specimen, an organism that may look like, it's probably not a pathogen, but because of the presence of an EVD, say in that space, it becomes significant. So it's very important to mention presence of catheters or devices, or has the patient had any instrumentation or any manipulation of those sites. Very important to mention that, because that changes the natural state of those sites. And I mean, when it comes to swabs, pass swabs, we really discourage it. Sometimes you get a request form that says a pass swab has been presented, and in the history it's written pass oozing from a certain site. So we really encourage aspiration of if you find pus, whether it's intra-op or in the ward or whatever it is, if there is pus, kindly aspirate that pus and bring it in a container. You can even bring it, if you can even use the urine containers to bring that to the laboratory, because that is likely to give you a clearer picture, instead of picking a pus swab that will just give you a lot of colonizers of that surface that you're trying to swab, and you're missing out the pathogens. So that is very important. If you cannot get that, you also have the option of getting tissue. Sometimes you go to theater and tissue is being debrided and thrown away. So you debride infected tissue, and then swab a site and then bring the swab. That does not really make sense. So you are better off, if there's no pass to aspirate, bring the infected tissue to the laboratory. That will increase the chances of picking the pathogen of interest and managing that patient in a better way. Of course, when you talk about surgical tissues, there's the importance of that. If it's coming for culture, it has to come in saline. And if it's going for histological specimens, histological examination, it should go in formalin. So that confusion should not be there, definitely. So thank you so much for this. We do not encourage, there's a question about urine sample from catheter bag being allowed for culture. So it's actually not allowed. Yeah, we do not allow urine from catheter bags for culture. Thank you.
Thank you for those comments. Dr. Nyabanda, you can also give us your final comments. Welcome. Dr. Nyabanda, if you're with us, maybe we can have Dr. Kinuthia, Dr. Rosalind Kinuthia go first. And Dr. Rosalind, as you give us your final comments, please, I'd like you to tell us a bit more on the CPD for pharmacists. We've had a lot of questions on the same. Maybe you can just mention as you give us your final comments. Thank you.
Thank you, Daktari. I think mine is just to thank the presenters, Dr. Maritim, and all the wonderful comments from Dr. Kasim and Dr. Nyukuri. And for me, I believe if we follow these guidelines and they do proper diagnostic stewardship, we will end up improving our use of antimicrobials so that we have rational use of medications. And this definitely will improve patient outcomes and reduce cost of care. So that will make our work as AMS committee much easier and also improve the outcomes for the patients and what they expect from us. So I think from the issues of CPD, pharmacy CPD. So KNH has been a registered site for PPB CPD provision, and we need to renew our subscription every year. So there is a bit of a delay on that, and that is why we do not have this webinar and the ones that are currently happening this week on the PPB portal. Ideally, when we have them on the PPB portal, the pharmacists and pharmaceutical technologists will subscribe and then attend the webinars, and that way you're able to receive a token. So to have a stopgap measure for this time, we are encouraging you to use the self-reporting icon, where you just click on it, and then it will ask you what webinar you need to claim points for. You give the name, and then you have to give evidence. So from after this, you will be receiving an email from KNH Research and Program to appreciate you or to acknowledge that you attended this webinar. So that's what you use as evidence for now. So as you upload that as your evidence, PPB will be able to collate that with the list that we have sent them, showing who actually attended this webinar for today and the ones for this week as you continue attending. So we hope with time we'll be able to get back to uploading the webinars on the portal, then you'll be able to subscribe. So for now, for the ones that are happening at the moment, please go the other route, and then you'll be able to still get your points. Thank you.
Thank you very much for that clarification. And Dr. Maritim, you can also give us your final comments, and we really appreciate your presentation and for even bringing on board this robust group of panelists that have really helped us understand understand all this. Thank you very much. Welcome.
Thank you so much for this opportunity to present on the webinar today. I think I'm so elated because of the number of participants who were able to log in. But more importantly, I'm happy because of the discussion this topic has generated. And I know all of us will be working very hard to make sure that we utilize our brand new lab fairly well. For people who are calling, who are logged in from the counties, and I could see my friends from MTRH, Christina Koru and others, I know you've learned a lot, and we'll work closely with each of other facilities. And I've received a note from, I think, Thika, who have been able to log in to see how we can encourage clinicians to use the lab, because this has been a challenge. I participate in another webinar eco series that's coordinated by the National Public Health Lab. And there are just a few of us who are clinicians who log into that because it's largely a laboratory-based webinar. But the cry from the laboratory team is that in facilities even that have very good laboratories, clinicians are not sending samples to the lab. They're not sending adequate samples to the lab, and therefore the lab remains underutilized. And this is a paradigm shift we want to change, because we want to appreciate the lab. In settings where we've had the opportunity to rotate for infectious disease overseas in the US, infectious disease is very evidence-based, because when you log into your system, they have a very good electronic medical record. When you log into the system, you get all the patient's detail. It will even tell you that Staph aureus was isolated from the blood and it's sensitive to this. So your role as an infectious disease specialist, when you're doing your consult, you just prescribe treatment. But in our setting, because most of the time we've sort of disregarded the use of the lab, we just want to prescribe even before we've investigated what is the actual organism that's causing the infection. And this is something we want to change. All of us now, we want to embrace where we send samples to the lab and we modify our treatments based on the results that we get from the lab. And really, I think this is very encouraging that people are willing to embrace using the lab and will fill the request forms appropriately and provide all the necessary detail that's required of us. So we'll share with through mailing list additional sessions and the dates of those additional sessions, because this seems to be a very topical issue, and the amount of discussion that we've had really suggests that there's a lot of need and demand, and we want to meet you at your point of need. So we'll have a lot of sessions to talk about specimen collections, appropriate sample collection, interpreting the results once you get the results from the lab, and even how to choose and prescribe different antibiotics, and then incorporate antimicrobial stewardship, because that has to do with the right dose, the right duration for the right bag and the right patient, so that in the end, we are stewards of both infection prevention, diagnostic aspects, as well as even antimicrobial stewards. So thank you so much for this opportunity, and thank you for staying up to the end. And we really want to thank our moderator. She's done a very excellent job. And also to thank my panelists, our panelists who've been very, very good and very interactive and taking a lot of questions. I think I just made the presentation. The rest of the Q&A was taken over by the rest of the panelists. So I really want to appreciate all of you and really look forward to future webinars touching on microbiology. Thank you so much, Dr. Jambanda and the hospital management team. We really appreciate the support you've given to all of us. Thank you so much. We really appreciate all of you. Over to you, Agnes.
Thank you very much. Dr. Nyabanda, you want to say something?
Yeah, I would just like to thank Dr. Maritim and all the panelists. It's really been a rich discussion, which has drawn a lot of interest. And I would like to thank everybody who has attended this webinar. And we hope that we'll have many more, as she is saying. It's actually For KNH, we are really committed to make sure that we give the best patient care. We have even developed a policy on AMS, the antimicrobial stewardship, that will soon be, there's a draft which has been taken to the board, so it will soon be a policy. And I think most of you in KNH have participated in it, from pharmacy, from the laboratory, and also infectious disease. So it's really a good time for us to forge forward and to really give the best care that we can for our patients. So thank you very much, and thank you even for the moderator and for everyone who has attended. Asante.
Thank you very much. Thank you all. We've indeed had a wonderful and a very informative session. We've now come to a close of this webinar. Please do join us tomorrow. We have another webinar on where we'll be talking on the role of genomics in NCD. We'll be having a team of colleagues from Arua, and we'll be going through that. And also today, actually, even today, we have another session in the evening on transforming culture of care to improve preterm survival. Today in the evening at 7 to 8:30 p.m. You are also very welcome for that session. Very informative sessions we have lined up for you this year. So feel very welcome. My name is Dr. Agnes Kazengo Karume from Kenyatta National Hospital. Do have a lovely afternoon, a lovely evening. See you. Thank you.